You know what keeps me up at night? It's not the complicated surgeries. It's the simple ones. The ones that sound routine. The ones where the paperwork is ready, the surgeon is confident, and the family is told, this is standard. I've sat with too many families after those standard procedures, holding a hand that's trembling not from age, but from confusion, pain, or loss. A daughter once whispered to me, "He went in for a hip replacement, and he never came home the same." That sentence changed how I practice medicine forever. Because here's the uncomfortable truth no one advertises. For a body over 60, some operations aren't just difficult, they can be devastating. And today, I'm going to name 5 of them. Not to scare you, but to arm you. Because an informed patient is a protected patient. My name is Dr. Williams James. For 25 years, I've been a practicing physician in internal medicine and geriatric care. I've treated patients in hospitals, clinics, and their own living rooms. My entire career has been about one thing: helping your body thrive at every age, especially after 60. This channel is for you, to give you the clear, honest medical information that too often gets lost in a 10-minute doctor's visit. We live in a world that worships youth and often treats aging like a disease to be fixed with a procedure. But your body after 60 is not a young body with wrinkles. It's a body that has earned its wisdom and its vulnerabilities. The heart's valves may stiffen. The lungs don't expand as easily. The liver and kidneys filter more slowly. The brain's resilience can wane. These aren't failures. They are facts of a long, well-lived life. And when a surgeon recommends an operation, they are often looking at the problem, the blocked artery, the worn joint, the tumor, not always at the whole person. The 78-year-old with mild heart failure, the 82-year-old with early dementia, the 75-year-old who lives alone. The risk isn't just from the disease. The risk is from the treatment itself. According to the American Geriatric Society, adults over 65 account for nearly 40% of all surgeries, yet they experience a disproportionately higher rate of complications. This isn't about age discrimination. It's about biology, and it's about time we talked about it openly. Let me give you a simple way to think about it. Imagine your body as a classic car, a beautifully maintained 1965 Mustang. It still runs, but it doesn't burn fuel the same way. The hoses are a bit more brittle. The electrical system is more sensitive. Now imagine taking that classic car and entering it in a high-speed demolition derby. The engine might seize, the fuel line might crack, the wiring might short out. That's what major surgery can be like for an older body. General anesthesia is a controlled poison. It puts every system into a state of stress. The heart, which may already have some artery narrowing, has to pump harder against the effects of the anesthetic. The lungs, which may have a touch of scarring or reduced capacity, have to oxygenate the blood while sedated. The kidneys, which filter more slowly, have to process a cocktail of surgical drugs and antibiotics. And the brain? It's bathed in a chemical fog that can take weeks, sometimes months, to fully clear. This post-operative fog isn't just annoying. It can trigger a cascade of falls, confusion, and loss of independence that becomes a new, permanent baseline. The surgery fixes one problem, but can create 3 others. So which 5 procedures carry the most hidden, life-altering risks for people over 60? These aren't necessarily the most common, but they are the ones where the gap between the advertised benefit and the potential cost to your quality of life is the widest. They are: 1. Complex spinal fusion for chronic back pain. 2. Aggressive cancer surgery in frail patients. 3. Elective major joint replacement without prior optimization. 4. Open heart bypass surgery, CABG in the moderately frail. 5. Emergency abdominal surgery, like a bowel resection. Now I need you to hear this. This list is not a prohibition. It is a provocation. It's meant to make you pause and ask, is this right for me, right now? Because the decision to operate is the most important medical decision you will ever make. And too often, it's made in a whirlwind of trust, fear, and urgency. Let me tell you about Eleanor. She was 79, a retired librarian with a sharp mind and a spine that had worn down over 40 years of standing at a reference desk. Her MRI showed significant arthritis. Her pain was constant, a 7 out of 10. She was referred to a top spine surgeon who, after a 15-minute consult, recommended a 2-level spinal fusion. "This will fix it," he said. "You'll be playing with your grandchildren again." Eleanor, eager for relief, agreed. The surgery took 7 hours. She spent 3 weeks in a rehab facility, confused and in more pain than before. The hardware irritated her nerves. She developed a stubborn infection at the incision site. 18 months later, after multiple revision surgeries, she was in a wheelchair. The pain was different. It was a deep, burning neuropathic pain the surgeons hadn't fully warned her about. The fix had permanently altered the biomechanics of her back. She told me, "I thought I was trading pain for relief. I didn't know I was trading walking for wheels." Her story isn't unique. It's a pattern I've seen repeated. The question isn't, can we do the surgery? The question is, should we? So, what do you do with this? You become the CEO of your own health. Here is your actionable checklist before any major surgery is agreed to. 1. Get a comprehensive frailty and cognitive assessment. Before you even discuss the surgery, ask your primary care doctor to do a formal frailty screen. Tests of grip strength, walking speed, activity level, and a simple cognitive test. This isn't about labeling you old. It's about establishing your baseline resilience. A body with a high frailty score will have a fundamentally different recovery path than a robust one. 2. Ask the "what if I don't" question first. This is your most powerful tool. "Doctor, if I do nothing about this blocked artery/knee pain/collapsed vertebra for the next year, what is the likely course?" If the answer is, "You'll likely be fine with medication and therapy for now," you have just bought yourself time. Time to get stronger. Time to seek a second opinion. Time to explore every non-surgical avenue. 3. Demand a prehab plan. If surgery is the agreed path, you should not walk into the hospital unprepared. Prehabilitation means a 4 to 6 week program before the operation to optimize your nutrition, especially protein for healing. Get your blood pressure and blood sugar under tight control, and begin a gentle physical therapy program to strengthen the muscles around the problem area. Studies show this can cut complication rates by up to 50%. If your surgical team doesn't bring this up, you bring it up to them. 4. Seek a least invasive first consultation. For every surgery on this list, there is often a less invasive alternative. A catheter-based valve repair instead of open heart surgery. A nerve ablation or targeted injection instead of a spinal fusion. Stereotactic body radiotherapy instead of a major lung cancer resection. Ask directly, am I a candidate for the least invasive approach available? If not, why not? 5. Have the hard conversation with your family. Not in the hospital hallway. Now. Discuss your wishes. What does quality of life mean to you? Is it being able to walk independently? Is it being pain-free? Is it staying in your own home? Write down your answers. This clarity will be your family's guiding star if a sudden emergency surgery is ever needed. If this kind of clear, no-nonsense guidance is valuable to you, please subscribe to this channel. My mission is to help you navigate your health with confidence, not fear. Hit that subscribe button, and let's keep this conversation going. Let's bring it home. The 5 procedures we discussed today: complex spinal fusion, aggressive cancer surgery and frailty, elective joint replacement without optimization, open heart bypass in moderate frailty, and emergency abdominal surgery, all carry a significant risk of permanently altering your independence. Not because the surgeons are careless, but because the human body over 60 has a different set of rules. The goal isn't to avoid all surgery. The goal is to ensure that if you have surgery, it has the highest chance of giving you back more good years, not taking them away. Your age is not a liability. It is your history. And you deserve a medical team that treats your whole story, not just your latest chapter. So, I'll ask you, what is the one question you will now ask your doctor before any major procedure? Write it in the comments below. Let's build a library of power questions for each other. If this video helped you see your health choices more clearly, please share it with someone you love. That simple act could be the nudge that helps a parent or friend avoid a life-changing mistake. Take this information, use it, and be your own best advocate. Because the most important voice in the examination room is yours. Everything I've shared today is general medical information based on current research and clinical experience. It is not a personal diagnosis, a treatment plan, or a recommendation for your specific situation. Every individual is unique. Always have a thorough, unhurried discussion with your own physician or surgeon about the risks and benefits of any procedure based on your complete health profile. They know your body best.